Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. At any time during today's presentation, you may submit your questions electronically by typing them in the chat window located to the right of your slideshow. At the conclusion of the presentation, we will also take audio questions, and at that time, instructions will be given as to the procedure to follow if you would like to ask an audio question. It is now my pleasure to introduce today's first presenter, Ms. Elisa Arispacochaga.
Thank you, David, and welcome this afternoon to the Physician Leadership Forum's webinar on preventing physician burnout, what hospital leaders can do to make a difference. To present today's session, I'm really pleased to have with us two fabulous speakers, Dr. Paul DeChant, who is with Simpler, an IBM Watson Health company, and Dr. Diane Shannon. And they'll be discussing physician burnout and what healthcare leaders can do to really reduce the drivers of burnout and return joy to patient care. Now, their bios are in the materials, and we'll be posting these on our website after the program. But I'm really pleased to have them available to do this. With that, I don't want to take any more time, and I'm happy to turn this over to Dr. Shannon to take you through the beginning of the presentation. Dr. Shannon, the floor is yours.
Thank you. Good afternoon, everyone. I want to start by asking the question, why is burnout a topic worth our time and attention? Physicians are in crisis. Evidence suggests that only about 10% of physicians would recommend medicine as a career. More than half of physicians surveyed have at least one feature of burnout. And almost a third of young primary care physicians say they're going to leave practice within 5 years. This suggests we have a problem. So why is a crisis among physicians important? This is data from Kate Shanafeld and other researchers at the Mayo Clinic. Population, physicians have significantly higher prevalence of burnout. And not only that, but when the researchers looked at data from 2011 and compared it to 2014, there was a significant increase in physician burnout, while that of the average U.S. worker remained steady. And what this says is that about half of physicians are experiencing burnout. If we have 850 physicians in the country, that means that right now, somewhere around 450,000 physicians are experiencing burnout. Now, why is that important? If over half of your medical staff are not performing to their top potential, it hurts an organization's ability to perform on quality, service, cost, and growth metrics. Now, Shanafelt and researchers also looked at another measure, which was satisfaction with work-life balance. What they found is that while the average U.S. worker was more satisfied with work-life balance, physicians had a decrease in their satisfaction with work-life balance from 49 to 41%. Now, what does this mean? Well, what would a physician do if they're experiencing a decrease in their work-life balance or dissatisfaction with it? They respond by reducing their workload, by reducing their work hours. So if you have a primary care physician who generates $1.5 million a year in revenue for the hospital, a 20% drop in FTE going from 5 days to 4 days a week would translate into a $300,000 reduction in hospital revenue. So this is an important issue for CFOs and other leaders to pay attention to. What are some of the consequences of burnout? Well, first, there are patient care consequences. Burnout has been shown to be associated with an increased likelihood of medical error, suboptimal care practices, and unprofessional conduct. Not only this, but there are other costs. In addition to the effects on the hospital revenue, replacing a physician is expensive. It has been estimated that if a physician leaves and needs to be replaced, the cost of that recruitment and replacement is somewhere between $250,000 and $500,000. So that can add up really quickly. In addition, there's a human toll. Burnout is associated with alcohol abuse and dependence and with suicide ideation. Now, I was not aware of this until just a few years ago, but the risk of suicide among physicians is much higher than that of the general population. In fact, among female physicians, it's 130% higher than females in the general population. For males, it's 40% higher. Now, that translates into somewhere around 300 to 400 physicians dying every year by suicide. That is the equivalent of 2 graduating classes from medical school. And suicide is just the tip of the iceberg in terms of physician suffering. Now, you might ask, are there certain fields that are more prone to experiencing burnout? There is some suggestion that emergency medicine and primary care specialties are especially hard hit by burnout. But if you look at these numbers, and this is data from 2016, you can see that even at the lower range, we're talking more than 1/3 of physicians reporting burnout. And data from just a year later in 2017 shows even worse statistics. Why? Why is the prevalence of burnout among physicians getting worse? Dr. DeChant and I recently finished a book published in December on preventing physician burnout. We spent about 18 months interviewing physicians and experts in burnout and health system leaders. And as part of that, we developed an idea, a model, that looks at 3 levels of drivers of burnout. The first level has to do with the individual physician. So those are stressors that an individual brings with them to work every day. Now, for a physician, that includes high educational debt. For many physicians today who are leaving training, they're coming out with debt somewhere in the $300,000 range. That is a lot of stress to carry. There's also the inherent stress of practicing medicine and the acculturation within medicine that says you cannot have any weakness. The next level is the workplace. Now, these are factors that are present in the immediate work environment of the physician, frustrations and barriers to care. These can create a toxic workplace environment. The third level is the external drivers. Now, those are factors that are outside of the hospital or health system or physician practice that put pressure on that organization, which is then transmitted to the physician. What are some of these factors? The EHR, meaningful use requirements, the CMS with its increased regulations and the regulatory burdens related to ACA and MACRA, star ratings for hospitals, payers who sometimes will use the EHR to then deny payment, ICD-10 and its applications, Press-Ganey surveys, patient demographics changing, including an increase in chronic disease and changing patient expectations, leading to physician or patients coming to their physicians with information that they've obtained from the internet, some of which is great and some of which is not so great. And Yelp and other ways that patients can review physicians online, also increased restrictions or regulations related to maintenance of certification requirements. And finally, reduced reimbursement so that physicians are paid less per unit of service. These external factors are what have changed over recent years. And these are what are leaving many physicians feeling that this is what their career is like. Being trapped in red tape and clerical duties and other forms of non-direct patient care, when that's not what they entered the profession to do. For me, I left practice because of burnout many years ago. This was before the EHR, before MACRA, before ACA, and some of these other external factors. For me, when I look back now, I can say that the reasons that I left had more to do with this, with the chaos and the disorder. This was in the days before the IOM to Ares Human Report, and there was much less understanding about the importance of patient safety and what could be done to reduce the risk of harm to patients. For me, I carried around that sense that my patients might fall through the cracks, and it felt like I was working on a rickety bridge over a torrent of water. I found myself feeling hypervigilant, worrying about my patients even when at home, and over the years that took a toll during training and the brief time that I practiced. It felt too often that I was living in the red zone. And what I can say now is that I was reacting to a toxic workplace, one that had not yet acknowledged the importance of patient safety. Today, that's very different, and there is an acknowledgement of the importance of patient safety, but there are other new stressors that are causing burnout among physicians. Now, I was very lucky in that I landed on my feet. I took a position at a communications company. I began writing and eventually left to pursue a freelance writing career, which has been wonderful, and at the same time, I miss patient care. And I consider it a tragedy when a physician needs to leave. Now, in 2013, I told my story publicly about burnout and leaving medicine, and physicians began contacting me privately to tell me their stories. They would never tell these stories out in the public because of the concern about their reputations and their future career. But they have heartbreaking stories of individuals who are dedicated professionals who want to remain in patient care but feel that the situation is simply unsustainable. Their stories are what motivate me to continue talking about ways to prevent burnout. And I've learned a great deal about burnout in the past couple of years. When I experienced it and when I left, I actually had no idea that that's what it was that had caused me to leave. It was only in recent years that I read a definition of burnout and understood that that is what had caused me to leave practice. Professional burnout has three manifestations. Exhaustion, generally or originally described as emotional exhaustion, but now expanded to include physical and cognitive exhaustion as well. Depersonalization or cynicism. So that's a distancing of oneself from the emotional aspects of work, from the organization, its purpose, from patients, perhaps beginning to see patients as yet another admission or a number or a case. And the third manifestation is a loss of sense of self-efficacy. It's a low sense of personal accomplishment in one's work, feeling that one's work doesn't make a difference. Now, research suggests that cynicism is a manifestation that has the highest risk of progressing on to serious consequences. And I want to say that burnout is not a clinical diagnosis. That's important to know. It is also not just needing a vacation. It is not depression, and it is not just feeling tired. It is actually a natural human response to extreme stress in the workplace. Research from Christina Maslach, Michael Leiter, and Mark Linder has identified some of the drivers in the workplace that are predictive of burnout. The first is work overload. For physicians, that's often time pressure related to productivity pressure in many cases, chaotic work environment. Now, this is something that I experienced. Second is the loss of control over their schedules, sometimes over decisions about patient care. Insufficient reward, that includes financial, but also the non-financial rewards, recognition, respect. Breakdown of community. Many physicians are more isolated than in the past from their colleagues. Absence of fairness. An example of this would be a situation where certain physicians, possibly the high income generating physicians, are treated differently from others in the hospital. And when there is a conflicting value, so that what the apparent value of the organization is conflicts with what the physician feels as their personal values. It's important to note that burnout is not the fault of the individual. For many years after I left, I did think it was my fault. I thought that it was a reflection of weakness on my part to not be able to hack it. But actually it's a mismatch between the worker and the workplace in those domains identified in the research. And when you think about it, if more than half of physicians are experiencing burnout, it wouldn't make sense that this is a reflection of individual weakness or susceptibility in the individual. Instead, it's a result of putting hardworking professionals into a toxic workplace where they can't possibly succeed. And as a message to physicians, if you are feeling burnout, it is not your fault. I think that message is also important to be able to identify effective prevention strategies. What is your role as a leader in reducing burnout? I want to go back to some data from 2015 from a survey of physicians, and it was compared to a similar survey done in 2011. Now, the survey results showed that about 2/3 of physicians reported more stress and burnout than 4 years ago, and almost half of them reported severe stress and burnout. But interestingly, only 18% said they felt their organization was offering help. The rest of this presentation will describe what you as a leader can do to change that dynamic and offer effective help. So what can an organization do about burnout? Well, if you think about that individual level, it's important to increase the individual's resilience to stress. That can be helpful. So an organization can start or strengthen a physician wellness program. There are some great examples out there. Here are 3. The Steps Forward program is a set of modules created by the AMA and under the leadership of Christine Sinsky. Ted Hamilton of the Coalition for Physician Wellbeing has some information. And Rebecca Smith-Coggins of Stanford has the WellMD program. There's some good examples. An organization can also offer burnout coaches. These individuals can be especially helpful for physicians who are experiencing acute burnout symptoms, but also for those who are at risk for burnout. And these are a list of 3 examples. But are these wellness approaches enough? Well, I wanted to leave you with some quotes from 2 individuals we interviewed for our book. The first is a burnout coach, and he said, "It's like we're putting physicians in the middle of a busy 5-way intersection with no one directing traffic and then asking them not to bleed so much." And the second quote comes from a primary care physician. He said, "Each day we wear down physicians by the death of 1,000 small cuts." So what we're talking about is a toxic work environment. And that needs to be addressed as well. And as Kate Shanafelt, the researcher from the Mayo Clinic, said, we need evidence-based interventions that address the contributing factors in the practice environment rather than focusing exclusively on physician self-care. Fixing the toxic workplace is critical to preventing burnout. And Paul is now going to talk about how to do this.
Thanks, Diane. So yes, let's take the rest of this time and talk about what we can do to fix the workplace. And our belief is that a great approach to doing this is actually to use lean. Now, you might look at that and think, well, wait a minute, I've seen lean come in and actually cause burnout. And that can happen when lean is done wrong. If lean is looked at as strictly a way to remove waste, improve efficiency, and drive productivity, it can definitely cause problems rather than resolve problems. But that's not lean as it was started at Toyota or as it is intended to be. And so let's talk about that some. Lean done right actually is done in a way where we focus on continually fixing broken patient care processes, not simply removing waste, where we focus on eliminating the frustrations that the caregivers experience. And this work has to be led by the caregivers themselves in their clinical sites. It can't be done by a committee in a conference room somewhere, but it should be done under the caring guidance of a mentor who has experience doing this. When we do this properly, then we actually have the opportunity for lean to become preventive medicine for burnout. And so let's talk about what lean looks like when we do it in that context and how that applies to management. The first question I like to ask people is, who's the most important person in your organization? And hopefully everybody in healthcare, their answer is, of course, it's the patient. Because without a patient, we have no reason for our healthcare entity to exist. And what's the most important thing we do for that patient? Everybody on the front lines who's taking care of a patient, who interacts with a patient, has the opportunity to make every one of those interactions a healing interaction. Some way to relieve anxiety and pain, to reduce suffering, to actually, to fix something that's broken, to educate somebody to be healthier. So those healing interactions are the most important thing we do for the most important person, the patient. And who's doing those? Those people we see here on the front lines, they're doctors, they're nurses, they're also receptionists, they can be EVS workers. Anybody who comes into contact with a patient has an opportunity to provide that healing interaction. As a family doc for 25 years, I had probably close to 100,000 healing interactions in my career. I then became CEO of a 300-physician group, and I stopped seeing patients. And at that point, I was not doing those healing interactions. If I wasn't doing my job right, then I became waste. My job was to make sure that those people on the front lines had everything they need in order to be able to do their work as well as possible, to provide those healing interactions as effectively as possible. That is the focus of lean done right. And that should be something we always keep in mind. So when people talk about patient-first programs, let's put the patients first, and then physicians oftentimes in frustration say, well, what about the physicians? Shouldn't the physicians come first because we're the ones that are providing the patient care? My philosophy is that for the frontline caregivers, for the physicians, the patient comes first. But for the administrative people, the frontline caregivers come first. So physicians come first for the administrators. The patient comes first for the people on the front lines. And when we do this right, then we're following principle-based lean, and there's two key principles in lean. The first principle is respect for people, and that really requires a significant culture change for many of us in healthcare. We like to think we're very respectful, but in my experience, seeing some very advanced lean manufacturing sites, I've realized that there's oftentimes higher respect for people, for the workers in those sites than what we find in our own cultures as we're dealing with all of our challenges. Respect for people, the way that we manage with that includes seeing systems, not people, as the problem. It includes leaders and administrators going to where the work is done to see and learn the actual challenges. It includes entering into a lean redesign with a no layoff philosophy, because as we ask people to improve work processes, if they design work process that takes their job away, we can't have them be at threat of losing their job. And it requires this deep sense that everybody matters. If you read one book in the next month, I'd highly recommend this book here. It's written by Bob Chapman, who leads a large manufacturing enterprise. He has over 80 manufacturing sites in 17 countries, producing with 8,000 people with over $2.5 billion in net revenue. He came to the realization a number of years ago that he wasn't treating his own workers effectively and properly, and that he could do better if he actually treated them like family members. He tested this in one site, and when he found great success and wanted to spread that, he turned to lean as the way to actually have a mechanism by which he could spread that throughout all of his sites. So this is a great book, and I highly recommend it. The other principle of lean is continuous improvement. Now, pretty much everybody on this call, hopefully, has experience with some form of huddles, with PDSA, maybe not yet with value stream improvement, but as you get into working with lean, that will come as well. The really important thing to understand is we can always get improvement, but if we want continuous improvement, we can't do that if we don't have a culture that's deeply based in respect for people. So let's talk a little bit about these lean approaches and what actually happens when we implement lean improvements. The first thing we want to do is focus on this, removing barriers and frustrations from the work that we do. And we do that through a process called value stream mapping, in which we identify the way a value stream is, the way of flow of a patient through a care process actually goes originally, and then we identify those things that are becoming problems or that create problems in care of the patient, and then plan steps in which we can remove those barriers. We have week-long rapid improvement events. We have projects that are much more complex, take longer, and then there's things we call just do it's, which are things we can do very quickly. They're the kind of obvious things that happen and that you identify as you're going through mapping out a workflow. You just look at it and go, why have we been doing that? We don't need to do it. Let's just stop. So this work is important that it's done by the people who do the work. Again, we're not taking a committee of administrators, putting them in an office somewhere or conference room somewhere and having them map it out. It's the people who actually do the work that make the difference. And if we don't include physicians in this work, then we're not going to design the work properly. So it's absolutely imperative that doctors are involved as we're redesigning workflow that involves doctors. Second thing is to think about the types of waste that we're talking about. How do we remove those frustrations? It's very common in lean to think about 7 different types of waste, and they're listed here. I won't go into everyone in detail just in the sake of time, although it's worth noting that for waiting, the New England Journal had a report about a year and a half ago that studied this and said in the U.S. there's about 1 billion hours of patient time spent waiting for health care across the United States each year. That translates into about a $52 billion impact to the gross domestic product each year. So when we think about what good our waiting rooms are and how we try to make them look nice, we need to be focused on something else. The more concerning waste for me is this waste of unused human potential, and particularly for physicians. A lot of that is spent entering data into the EHR. In fact, we have a separate chapter in the book simply on the EHR because this is such a serious issue. And there's been a lot of studies that are bringing this more and more to light. Although I'll tell you, as a physician myself, when I first started using the EHR, I spent many hours at home entering data and honestly fell asleep on the keyboard many a night when I was trying to catch up from the work that day. So there are studies now that are showing that there's 2 hours of administrative work for every hour of direct patient care. In fact, even in the exam room, we're more distracted looking at the screen and putting our hands on the keyboard rather than looking our patients eye to eye and using our hands to examine and comfort our patients. And people are spending time doing work after work. In fact, it's becoming, we can study this with most EHRs, actually can look at the time that docs are in the EHR working and study that throughout the course of the day. So we do see, obviously, while people are in their clinics from 8 to 5, a lot of time and activity in the EHR. It tends to drop around dinner time, but then it pops back up again later in the evening, 7 o'clock, 8 o'clock, and actually we've come to label that as pajama time, or people are seeing it even on Saturday nights, which is really pretty sad when you think about it. It's also ended up with decreased interaction for colleagues, both in the hospital and in the office. If you go through your hospital, it's common to see the hospitalists all working together in a room, but they're not actually working together. They're all sitting side by side typing and not interacting with each other. Radiologists have been tremendously impacted by this because it used to be that every attending physician would rotate down to the radiology suite in the morning and review films with the radiologist. Now radiologists sit at screens rapidly reading films. Nobody has to come by because the images are all on the screens up on the floors. And many radiologists don't even know if the physicians are actually even reading their reports. So there's been tremendous impact in many ways with the digitization of healthcare. Let's talk about some other steps that can make a difference in helping solve this problem. Daily huddles are important for solving problems rapidly at the front line. And in a huddle, for it to work well, we should have everyone participating and actually develop them to the point where staff are effective at leading the huddles themselves. When we do them right, we can prepare for the day. So we're ready for any, as much as we can, what's going to happen that day. If we have the capacity to meet the demand in terms of staffing, equipment, supplies, etc. We review performance metrics to be sure that the unit's addressing key things that improve the overall performance of the organization. We'll talk a little more about that later. And we can solve problems in real time. These huddles should be coached by leaders, but not led by leaders. And that attending the huddles so that as leaders you know what's happening and what the challenges are your people are facing is important. But actually leading the huddle to empower people on the front line, it's best to have the frontline staff themselves engaged in leading those huddles. When we do these huddles properly, we end up with tiered huddles where we can, as staff identify problems at the front lines that they can't resolve themselves, they can escalate through a series of tiered huddles that can, in effective lean organizations, actually can go all the way to the level of the CEO within a single day, and make sure that as the CEO, you're aware of what the challenges are for patient care for your frontline staff, and aware of those immediately so we can respond quickly. Now, while we've got the staff at the front lines working like this, we also, while we empower them, we want to be sure people are aligned well. And we align around what in Lean we call true north metrics. These really are the same dashboard metrics that most people see and work with, and we measure ourselves on in pretty much every healthcare organization. And while quality, safety, delivery, patient satisfaction, cost, and growth are important, the one that we focus on more significantly in Lean is actually human development, both in terms of staff and physician engagement, and even developing metrics for joy in patient care. When we think about that loss of that insufficient reward that's a driver of burnout, being able to practice in an environment where we find joy in the work we do should be an intrinsic reward that everybody has an opportunity to experience. As we develop these true north metrics, then we actually use this process. This is how we align the organization, is from the C-suite. We can then identify at each level going up closer to the front lines how those metrics play out, what those metrics should mean for the organization as a whole, at the director level, at an individual unit level, and ensure that we've got alignment throughout that process, that we've got people understand the mission and vision of the organization, that they understand the core values, and that we can communicate those well. And this is really important because the CEO's role in the Lean transformation is to lead that transformation. In fact, when we see, I coach at many health systems around the country, and oftentimes Lean transformations really struggle. And in the vast majority of those cases, the reason it struggles is because the CEO has not been engaged in putting that whole process together. It's something that can't be delegated and is vitally important. And part of that process is actually going to the Gemba, because when you go to the Gemba, we do two things. Not only do we attend the huddles, but we shadow people as they do their work. And spending half an hour with just quietly and shadowing a physician or a nurse as they're getting through their day, trying to take care of patients, and being able to observe the challenges and frustrations that that caregiver has as they're attempting to do their best to take care of a patient can often inspire people to do, in leadership positions, to become much more committed to transforming the organization and making a difference. When we put all this together, when we've got a CEO that's committed, when we have a lean management system with the value stream improvements, with daily huddles, and with alignment, strategic alignment throughout the organization, then we can actually create a lean management system and culture that can quickly adapt in an environment of volatility and uncertainty. And as Darwin has famously said, it's that ability to adapt, to respond to change that's most important. In fact, some of the most prominent lean leaders, when they're asked, how does strategy apply to lean, their response is that lean is the strategy, because when we live in an environment that is very uncertain, the key to success is being able to respond quickly to whatever those uncertainties are. And when we can identify a problem and quickly at the front lines effectively deploy a solution, then we have an extremely responsive and effective organization. What kind of results do we see when we do that? I'll share with you some examples, from personal examples as well as with some of my colleagues. When I was CEO of Sutter Gould Medical Foundation, a 350 physician organization in the Central Valley of California, during our lean journey, we were able to reduce our average speed of answer from our call center down to 2 seconds. We actually, in our lab, if you look at the yellow box there, we reduced the turnaround time for getting lab results back to urgent care from 40 minutes to 20 minutes. At Kaiser Permanente in the Sacramento area, they reduced their backlog in days for major imaging studies from 2 weeks to 0 days. We had, at Gould, we had great financial performance as well. And we were really surprised when we found out that Consumer Reports had actually done a survey of 50,000 Californians and came out with the results of that survey in an article that we weren't expecting, that gave us the highest overall rating of 170 medical groups in the state of California in 2014. They repeated that in 2015, and we received that same recognition the following year. We felt that was pretty good validation for the effectiveness of doing this work. And while you can look at that and think, they must be working their people pretty hard if they're achieving those kind of results, we actually drove our physician satisfaction scores up significantly as well to the 87th percentile. So what's your role in change? I'm assuming that most people on this call have a leadership position in a hospital or healthcare system in some way. The real key is that we personally have to change. If we're going to be effective, if we're going to address physician burnout, it's not something that can be delegated. We all have to be personally involved. So there's a number of action steps that we recommend. The first is that people learn about burnout, both physicians and leaders. And so surveying the people in your organization and studying the literature is key. For leaders also, as you do this, educating your board of directors and ensuring that they're aligned with this work is important. In fact, there's a great journal that's available for free online called Burnout Research. It's edited by Christina Masloch, who developed the Masloch Burnout Inventory, and it's a great resource among others. The second is people need to take care of themselves. We can't be effective if we ourselves, whether as physician leaders or non-physician leaders, if we're burned out, and burnout's a problem not just for docs, but for nurses, for administrators, for many people dealing with the stresses of healthcare, we need to get involved. So, we need to take care of ourselves in this process. Make sure you're taking care of yourself, check in on each other, develop a physician wellness program. If you see a colleague you're concerned about, pay attention, talk to them. They will appreciate it, because they're probably suffering silently and are afraid to have anyone actually afraid to share that proactively, but will appreciate it when somebody reaches out. Next thing is to work with each other. Physicians and leaders, oftentimes, as we're all dealing with the stresses of as physicians trying to take care of our patients, as leaders trying to simply keep our healthcare organizations solvent and functioning effectively, we can look at each other as the problem rather than look at each other as potential partners to address this major challenge. So as physicians, we need to get involved and participate in every opportunity we can. And as leaders, we need to involve doctors in strategic and financial planning, and we need to connect with them in both formal and informal ways. And building these relationships is one of the most important things we can do in the process of addressing burnout. And then, and in that participation, participate in lean activities if your organization is on a lean journey. Physicians in particular, we need to design our lean activities so that physicians can participate. And we need to support physicians to participate by providing a number of options that can make it more valuable for them to do so, including things like being able to get CME credits to provide compensation for the work physicians are doing when they get involved. Leaders can also learn more by shadowing physicians. And that first bullet there about implementing and upholding a no-meeting zone is very important. If we're going to be able to do true lean with true respect for people where we are in the Gemba, we need to have a protected time to do that. And if there's meetings if there's a time during the day when no meetings in your organization take place, then the leaders actually have time to get out to the front lines. And that's tremendously important. One caveat, if you do embark on a lean journey to address this issue or any other major change you make in order to address this issue, be cautious about overestimating how quickly a change can get accomplished in a large, complex organization. This is a quote that I really like from Bill Gates. It says that most people overestimate what they can accomplish in 2 years, but underestimate what they can accomplish in 10 years. As we see most lean transformations take place, usually around 18 to 24 months in, people get to the point where they're very frustrated. They're almost about to give up because we're driving such significant cultural change. But once we get through that, then we see change accelerate. We see the culture begin to change much more deeply, and we see tremendous improvements when people stick with it. So just be aware of that, in any kind of major change we're trying to accomplish, 2 years is a short timeline to see the full benefits. And that's tough in this environment these days because oftentimes we don't feel like we even have 6 months to respond to something, let alone more than 2 years. But sticking with these kind of major changes is absolutely crucial to see real success. So when we've focused only on the triple aim, what we have seen is an increase in burnout. But if we can truly pursue returning joy to patient care, pursuing the quadruple aim where we add wellness of physicians and other caregivers to the triple aim of high quality, low cost, and care for all, then what we can do is actually get to the point where we have frustration-free patient care. And with that, I'll hand it over to David, who's going to manage our Q&A session.
Thank you, ladies and gentlemen. At this time, the floor is open for audio questions. If you would like to ask an audio question, you may do so now by pressing *1 on your touch-tone phone. We'll take questions in the order they are received. If at any time you'd like to remove yourself from the questioning queue or your question has been answered, press *2. Again, to ask an audio question, please press *1 now.
And this is Alyssa again. While we're waiting for those questions, there have been a few in the chat box and actually a pretty robust discussion going on as well. One that I think addresses some of the things you just ended with, Paul, that I'd like you to handle is how does leadership really create the context for fostering that confidence and fostering that connection to providers? What are some of the things you've found?
Well, you have to, when you walk a mile in somebody's shoes, you can understand them a lot better. So it's really important. It's like this lean term of going to the gemba, going to where the work is done is so important. In fact, I was just at a lean conference in Europe, and the leaders there who had some good success made this point that the more time a leader spends in their office looking at spreadsheets, the more wasteful they are in the work they're doing. If you really want to understand your organization, if you really want to understand your people, you need to spend time with them, not with reports. One of the things that often I find both frustrating and amusing is that we all put a lot of emphasis on engagement, staff and physician engagement, and we'll get our surveys and they'll come back with action plans, and people will form committees and spend a lot of time thinking through committees about how to engage. Probably the best process to improve employee engagement is to empower them to solve the problems that are frustrating them, and having daily huddles where those problems can be brought forward and can be addressed is one of the most effective ways to do that, particularly when people see their senior leaders showing up and supporting them in that process.
Agreed. David, do we have any questions on the phone line?
At this time, we have no audio questions.
All right. One of the other points that came up in the chat that I noticed was the idea when you were talking about the EHR, and I know this is a discussion that's happened in many different places, and is the use of scribes and how that impacts the burnout related to EHRs. Then also a comment on auditing to see those who are in fact completing charts while in their pajamas, and how to maybe reach out to those folks. Have you seen anything along those lines?
Oh yeah, and as a lean coach, I try to stay away from providing specific solutions, but there are a couple of conceptual solutions that I think are really important. One is the idea of team care, where we surround people with teams that support them. No surgeon would go into an OR and try to do a surgery without a team in that OR because it's just too complex. You need the anesthesiologist, the circulating nurse, the scrub nurse. You need people supporting you so that the surgeon can focus on that most important thing. Well, the exam rooms getting to the point where it's approaching the complexity of an operating room, and yet we put physicians into an exam room by themselves, trying to contend with multiple complex problems with the patients, with an EHR that often has a user-unfriendly interface, and so docs spend 2/3 of their time with their fingers on the keyboard. So, well, it's just wrong. Scribes are one great solution. There's many ways actually of developing team care in the office where we can reduce physicians' clicks and mouse mileage by 90% and actually improve the quality of care and improve productivity. Oftentimes I find as we think about from a financial standpoint, it seems as though, particularly from lean, if we say we're not going, lean is all about removing waste. It's reducing the number of people. Actually, oftentimes it's best to increase the number of support staff so that the physician themselves can be more productive. And while that may sound like we're adding people on an absolute basis, if we look at adding additional costs on a relative basis for the number of patients seen, we're actually reducing the number of people involved and the costs involved in the number of patients seen, while dramatically improving the ability of the physician to do what we do best, which is to diagnose and treat our patients and have someone else do the recording that's involved. The other conceptual solution along with team care is co-locating folks. And this actually has gone away some with the electronics as well. It used to be when I was making ward rounds in a hospital, I'd stand at the nursing station while I wrote my notes and I could talk to the nurses about what was happening. And now oftentimes people are sitting in a different room typing and sending messages to each other. Similarly, in an outpatient office, if docs and nurses and MAs are sitting next to each other in between patients, they can just talk about all the messages that are coming into their in-basket without having to email each other about it. And that can dramatically reduce that after-hour time as well.
I agree. I think that's added sense of camaraderie of talking with each other definitely helps the situation. I don't think there were any other questions in the chat box at this point. And David, do we have any on the line?
No, ma'am, no audio questioners at this time.
All right. Well, I just wanted to take a moment and see if there's anything else either of you would like to add before we wrap up, but also wanted to say thank you for taking the time to share this with our audience.
Oh, our pleasure.
Yes, thank you very much.
All right. Well, again, thanks for participating in today's webinar. Oh, I'm sorry. We have another question. We have a question in the chat box. How do you handle organizations that require 24/7 physician access to patient portal or text?
So I'm interpreting that question to mean a healthcare system demands that the physician be available 24/7. If that's the case, I think there's a need for the physician leaders in that organization to work with the rest of the leadership in that organization and talk through it. If we can't get to a point where the physician leaders can connect with the physicians on the front lines and bring those issues forward if the physicians themselves can't do it individually. But if that can't get resolved, then maybe it's time to find a different place to work. Everybody has the right to a humane expectation of work levels.
Absolutely. Absolutely. Well, again, thank you for taking the time to participate on this call. For those of you who are listening in, you can find a recording of this session, and the slides will be available on our website, which is ahaphysicianforum.org, all one word, and those will be posted early next week. Again, thanks so much for taking the time, and happy St. Patrick's Day.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us this afternoon.